neurosurgery has particular demands. You know, we don't open the whole belly and look around and move the organs around and get a comprehensive view of all the anatomy like they do in general surgery. We're working often through very focal craniotomies, keyhole approaches in many cases, and so we need a comprehensive understanding of complex anatomy, because in neurosurgery you often see only one small fragment of the anatomy at a time. And there's a lot going on with not only with the vascularity of the brain and the cranial nerves and its relationship to the skull base, but also with the internal structure of the brain. So functional areas on the cortex and the connectivity of the brain all need to be taken into account as you plan various types of surgery. So imaging, to give us a full map of what we're planning to do in neurosurgical procedures, is critical to success. And that's why we've been so focused through the years on advancing imaging techniques. So I'm going to talk about imaging techniques, give you a little extremely brief historical perspective, and then talk about some of the things we're doing now with 3D imaging and virtual reality. So these are the generations of imaging that we've gone through, from X-ray to CT to computed tomography, CT and MRI scans. Stereotactic image guidance has become essential to our daily practice. Functional imaging more and more is integrated, and DTI and 3D reconstruction are key elements as well. So clearly X-rays are fundamental, computed tomography is key. And for image guidance, here's an example of how image guidance really has changed the way we do things. Here's a 35-year-old woman who's pregnant who sustains an intraventricular hemorrhage. She has a bit of blood there in the right lateral ventricle, and as we look at it more carefully, we see that there is an abnormality in the medial temporal lobe on the right side. Fairly small, several centimeters below the cortex, and angiography shows that to be a small vascular malformation in the brain. So reaching that historically would have been a significant challenge. It would have required a large craniotomy, dead reckoning as to exactly how to get in there, and probably a fair amount of exploration, because as soon as you get under the cortex, you don't have any landmarks, and you got to go through the temporal lobe to hit that periventricular lesion. So immediately you're in a sea of featureless white matter, and I can tell you, having been doing this for 30 years, in the old days, getting lost was not unusual. But now with image guidance, really you can set the procedure up ahead of time, rehearse your approach, determine the entry point, determine the trajectory. You can see that we have that red extension, as you well know from image guidance, is a virtual extension with the probe resting on the scalp at the beginning of the case. And so you can make a very focused craniotomy and get right on top of the vascular malformation. And it's key not to have to search around here, because the blue area are the fiber tract projections from the geniculate to the occipital cortex. If you divide those, you're going to have a hemiparesis, so you don't, or a hemianopsia. So you don't want to stray even a couple of degrees off target here. And so the image guidance system is very helpful. We actually see those two veins in the upper right. Those are good landmarks as to where the entry point is going to be. We've inserted the operative video here while we're doing the navigation. And here's the operation. So there are those two veins. Everything's inverted 180 degrees for the surgical perspective here. And so with faith and image guidance, we're going directly through a 1 centimeter incision into the lateral ventricle, sparing the visual projection fibers, and we're finding the vascular malformation. So here's the view of it. So we end up right on top of it with no deviation We see the main bulk of the malformation there, and coagulate it, and that's it. So that's an entirely different experience than what we might have done several years ago. So there's the size of the craniotomy, about the size of a poker chip in the temporal region, short incision, a whole different experience than it used to be. Here's the malformation, and then the postoperative scan. The next thing we have to take into account really are the functional areas. So the goal in surgery is twofold. Get to the lesion and address it, spare all the normal functions. And so it's critically important that one have an understanding of functionally important cortical regions, and eloquence certainly plays a role in deciding whether AVMs are operable or not, as well as deciding how to approach intraparenchymal lesions like cavernous angiomas or gliomas. And what we know from experience is these circles represent AVM nituses in a variety of areas through my experience. And what we know is when the AVM sits in primary motor cortex like that, there's not too many of those circles there, because we found that operating on those always causes a neurological deficit, a motor deficit. If you're behind the central sulcus, if you're in front of the precentral sulcus, you're okay. And very rarely do you have sustaining permanent deficits. And if it's one gyrus removed, you may have a temporary deficit for a while, but you don't have the permanent deficits. That only occurs in these particular ones. So location obviously is key for functional areas, especially with motor cortex. Now the language cortex is a little different. So this is the kind of map you see in neurology textbooks for language cortex. Here's receptive language area, here's Broca's area. But for every one of you in the audience, it doesn't look like that. There are a few discrete small areas within that area that are working for listening and reading for you that is different from the person sitting next to you. Everybody has their own map, and so for language cortex you have to make the map individually for each person in order to spare it. And that's where functional MRI scanning comes in. So these circles represent the percent of trials. This is actually right here from Dr. Ojim's work at the University of Washington. In this number of patients here, 20, whatever that says, 28%, 30-some percent of the stimulations in that area across all patients cause language deficit. But in many of the cases, there's no language function located there. So it's different for everybody. And look how widely dispersed language function is through the dominant hemisphere. So everybody has an individual distribution of a few of those points of language cortex. So for each person, you've got to make a map individually. And today we're fortunate to have functional MRI scanning, which allows us to make that map and use it for surgical planning for each individual. So this is how it works. The patient's in a long torpedo tube like MRI scanning. They're doing language-related tasks like looking at pictures and thinking of the word to name a bell, a boat, a key, a star, and doing this over and over until you get enhancement. This is actually an image of blood flow. So when metabolism in the language center goes up, the blood flow goes up. You can image that on MRI scans. That's a map right here. Well, this isn't quite a language map. This was an interesting experiment done in the MRI scan. I still don't know how they did that experiment, to tell you the truth. I would have loved to have been there to see it, though. But this is language stimulation on an MRI scan. So here we have a large AVM, dominant hemisphere. The question is, where is that in relationship to Broca's area? And when we did the map, we found areas of stimulation surrounding the AVM. Early in our experience, we were not 100% confident with that, so we would go on and actually do awake language mapping. Patient goes to sleep under general anesthesia. You do the craniotomy, expose the brain, let them wake up and extubate them in the operating room. stimulate the brain, and when you hit a spot that is active for language, they can't talk. And so you continue doing that in the whole region, and you'll find several areas where you stimulate and nothing happens. That's not an active language area. When you stimulate over an active language area, then they can't speak. And this is what the map looked like in this individual. So here's the AVM. Here's what we saw at surgery. There's a Sylvian fissure. It's right on the frontal operculum. Broca's area ordinarily is right in this general area. And what we found, we label the brain with paper tags. And a blank tag means there's no function there. And a lettered or numbered tag means it's a critical area for function that you can't disrupt with surgery. So this is what we found. Everything. The AVM had exploded Broca's area, and it surrounded the AVM. And when I saw that, I quit. I stopped. Because removing that AVM certainly would have left him with a disabling language deficit. So now, and that's what the functional MRI scan told us, and now I'm making a lot of decisions based on functional MRI scan. That one patient went on to stereotactic radiosurgery. What we also have seen, here's another typical case, left language lateralization in a patient with a little AVM back in this general area. So here is Wernicke's area, and there's Broca's area. Closer up, there's the AVM, Wernicke's area, Broca's area. This one actually is more than a centimeter away. We went in, removed it, no language problems. But we also saw some cases like this, a big AVM back here. Dominant hemisphere. Here's a closer view. Here's a large AVM, very close to what traditionally would be considered Wernicke's area. And we saw a normal located Broca's area, but Wernicke's area was shifted from the left hemisphere to the right by this congenital lesion that had been there all the patient's life and had caused some plasticity, some reorganization of brain function because of the location of that lesion. Because of the anatomy of this one, we actually never operated on that one, but we've seen this in a handful of cases where we see shifting of the language cortex, and that's another important thing to know. So that's how imaging can inform our treatment planning. Now today, with DTI type imaging, we're getting these amazing images of the wiring diagram of the brain. It's just remarkable how well you can see, because what I just showed you, Wernicke's area for receptive language function and Broca's area, in order for that system to work, they've got to be connected. They've got to have the nerve fibers working between those two areas to make everything work. And so there actually are fibers that go from Wernicke's area up to Broca's area, and if you divide those as well as disturbing the cortical area, you get a language deficit. So in this particular case, I showed you previously, it'd be great to have a map of all the fibers that are involved in vision so we can weave our way through them to get to that malformation and minimize any visual deficit. And now combining it with three-dimensional reconstruction gives us fantastic images that allow us to see the pathology, see the cortical areas that we have to avoid, see the subcortical fiber tracts that we have to work through in order to get to the lesion. And here's what we're seeing now. Tumor in a patient with a glioma, and we can see the cortical anatomy, we can see Broca's area and Wernicke's area. We know we can't be too close on the superior surface of the tumor, and the gold fibers here connect those two. So once we get to the deep part of the tumor, look, we're very close to those connection fibers. So we know on the superior and deep surface of the tumor, we have to be very conservative to stay within the tumor and not to disrupt that critical system if we want to keep language intact. So neurosurgery has progressed with progressive information about the precise structural details of the pathology that's allowed us to plan in an ever more precise way and informed way the surgical procedures. Virtual reality now is coming on as another potential way of getting an even better view, almost an experience with the anatomy. because my imagination has always been, I want to get right inside there. I want to be walking around the structures and seeing exactly how close the nerves, arteries, fiber tracts, functional areas are to the pathology. I want to experience it. I want to get inside it, and virtual reality is a way where we can begin to do that. So it's been around for more than 20 years. It has been limited by inadequate computing power, optics that aren't quite good enough, software that's not quite sophisticated enough. But over the last few years, we've seen some tremendous advances in virtual reality. How many people have put on a virtual reality headset, actually put it on and experienced it? So quite a few, a good 35, 40% of the people here. What I'm going to show you is a taste of how it feels, but anybody who's put it on knows you can't figure it out until you actually have the headset on and you're totally immersed in that virtual environment. But we'll give you a little view of what it looks like. So it's a new world with virtual reality now. And so this is one way of getting some idea of what it actually feels like. So they're going to film people in a way that shows you what the individual is seeing, what the environment looks like to them in virtual reality.
So we're going to show you some virtual reality today. It's really hard to show people what it's like to be in virtual reality without having them try it for themselves. Filming you in the green screen studio is just the best way we found to help everyone else understand what it's like to be in VR. Go crazy.
Aw, you're so cute. Oh, hi there, look big. Oh. Hey, I have a stick now. Come here. You want the stick? Yeah, go get it. Oh, he actually gets it. Come on. Oh, you're so cute.
It makes you feel like you're pulling a string back.
Left, check left.
Oh, yeah. Nice shot.
Oh my goodness, these guys are so cool.
Look behind you, Kyra.
So that's an experience called The Blue that was generated by a small company in LA. And I'll tell you, when you get in there, it is remarkable how it feels like you're standing on that shipwreck. Well, everybody started getting really serious about virtual reality when 2 years ago Facebook paid $2 billion for Oculus, a small startup developed by a kid who was 19 or 20 years old. And they had no product finished. They had 0 sales. But when Mark Zuckerberg, the CEO, saw a demonstration similar to what I just showed you, he said, this is clearly the future, and we want to be the first on board. And if you look, at like Google Trends and how people are searching for terms, if you type in virtual reality, it's exploded over the last year. And there's a lot of hype about it. And time will tell just how extravagantly this is exaggerated, but this is what is written in articles in journals like Forbes. And this is what people are seeing. So you are completely immersed. It feels like you're in that environment. And with 3D sound, it's only magnified. The key thing that's helping us in healthcare is that there are billions of dollars being invested because people are interested in gaming, entertainment, and other applications. And so the software and hardware are progressing much more rapidly than they do with things that are purely designed for healthcare, where the ultimate return on investment is not as high as something that's going to be picked up by millions and millions of people around the world. And so it really benefits us tremendously. SWAT teams are using it, astronauts are using it, pilots are using it to get better experience with complex tasks and trainings. And for crisis situations, it allows you to get into a situation and learn by making mistakes without a catastrophe. Obviously key for spine and brain surgery. And ultimately, people will be connecting through virtual reality so that they really feel like they're in each other's presence. So brain surgery is beginning to benefit from it. Let's take a look at how it works. As soon as you see it, one of the first things you want to see with these virtual images, if you're looking at a virtual skull, is you want to reach out and grab it and manipulate it. So these hand controllers allow you to do this. This is a system called the HTC Vive system, and we're also going to show you the Oculus system here on the demo. But it allows you to take two-dimensional images like CT scans, CT angiograms, MRI scans, and generate a three-dimensional model relatively quickly in 10 to 30 minutes. And then virtually rehearse the operation, do a virtual craniotomy. In this particular case, we were looking at the suitability of a supraorbital craniotomy for getting to this anterior communicating artery aneurysm. You can see a clip on the aneurysm there, so it's possible to digitize implants and fit them into the model and see if, for instance, the aneurysm clip has the right configuration and size, so you can select the right array of clips ahead of time out of the hundreds available. You can segment the different structures, so you see the ventricles in blue, the tumor in gold, the vascularity, the skull, and you can fly right into it and see it close up. So here's a view of how we're beginning to use it in our daily workflow right now at UCLA. In LA, close to Hollywood, we like to be understated and modest. Hi, Jody.
Hello.
Well, Jody, I know that we've talked about the fact that there's an aneurysm.
Mm-hmm.
We talked about the different alternatives for treating it, and I think the best way to go is going to involve a craniotomy, opening the skull and going in and closing the aneurysm off. I know you had some anxiety about it. We have the ability now to show you exactly what we're going to see during the surgery. This is a virtual reality headset, and this is going to give you a view as if you are seeing the aneurysm as we will in the operating room, and in fact, even better. We have diagrammed this three-dimensional reconstruction of your anatomy, exactly where the opening is going to be. It just looks straight in the hole, right up to the aneurysm. And if you turn around,
Oh, there's the back.
this right here is the view that no surgeon will ever get. This is the view from inside the head out. We're essentially rehearsing the operation now, so it gives me a tremendous sense of confidence before we go ahead with the surgery. So we'll clip the aneurysm, that will seal it permanently, and there'll be no cosmetic evidence that we were ever there once you heal up.
It helps a lot to be able to see what
Doesn't
that looks
it?
like.
Yeah.
I couldn't picture it before.
Okay, I think we're ready for the surgery.
Thank you so much, Dr. Martin.
You're welcome. Over this with you so that you get a view of what the challenges are. So you can see the tumor here on the axial image. The coronal image here doesn't entirely clarify where the carotid is. We just don't see it clearly enough. So let's take a look at it in VR here.
Okay.
I've got a full 3D view, and there's a carotid artery. We're right on it, and I can see exactly where it's coming out of the tumor right there. So this reconstruction is created from medical imaging like MRI and CT scans. So the flat planes are stacked, turned into a three-dimensional model, and then fed into the system so I can look at it from every possible angle. So I can get down below it and look up, come off to the side, and fly right back in. Now that's the Vive system that allows you actually to walk around in the virtual environment. It tracks your position. A tremendous sense of deja vu when I get to the operating room. So Alex, let's have you take a look. So we also use it for training in
So guys, we're going to take a look at
a room
a skull-based
configured
tumor
for
here today.
VR lessons.
So let's have everybody put on their Oculus headset, and we're going to take a look at this reconstruction. All right, superficial temporal arteries on the right.
See the avatars
And
there,
take a
I can
look
see where
off
the
to
individual
left.
residents
We're gonna
are
see
and
the
what their
skull-based
perspective
tumor
is.
here.
So if I'm talking about a
Relationship
tumor
with
in the
the
left
sphenoid wing
medial
there.
sphenoid wing and they're looking at the occipital lobe, I can reel them back
Better
into
view
where
than
they're
the
supposed to
OR.
be.
So this allows us to go through the anatomy of very complicated brain tumors and brain aneurysms with the residents. They'll have an intimate knowledge of the anatomy of some of the most classic kinds of neurosurgical problems. Not only do you get an incredible three-dimensional view, but you also get a memorable experience that really stays with you when you go into the operating room. You feel like you've been through the territory before. Oh.
So let's head to the operating room.
Okay, let's take a look at the case. So what we have is a lesion in the left temporal lobe here. Angioma. And what I want to do is fly right to the other side of the skull. There's a view of the carotid artery right there coming out. You see that? So I'm going to have to fly all the way past it.
So within a research protocol, we're beginning to use the Oculus right in the
Alex,
operating
take a
room.
look here.
And obviously, you can't use it while
See
you're
your
operating because all you
perspective
see
here.
is
Fly right
the virtual environment.
Great view of the tumor.
And now we'll talk about augmented reality and the ability to see both
Right
the
in.
real environment and the virtual environment as well.
I think we got the anatomy down. Let's go scrub in. And
So in one possible future, every resident's going to have to do 10 or 20 operations flawlessly in virtual reality before they touch a patient. When you take your board examinations, you're going to manage several virtual operations. And while you're exposing the aneurysm, the examiner will press a button and the aneurysm is going to rupture, and you're going to have to figure out what to do without fainting. So here's one situation, and this is one that I'm seeing more and more often. I'm beginning to use these smaller craniotomies for intracranial aneurysms. You have to be right on target, and you have to make sure that the aneurysm has the right orientation if you're coming in from a frontal approach or from a terional approach. So I can try both out in virtual reality and see exactly what the aneurysm is going to look like from that perspective. We can fly right up to it, try on virtual clips as we just showed. Here's a tuberculum cellum meningioma. Same thing. I wanted to see if we would get a good view through the supraorbital approach. Pretty good view. We can see that the carotids actually are partially engulfed. But what do you really want to see? Well, you want to see the backside of the lesion because you would need to see the posterior communicating arteries and the basilar artery and see, is that engulfed in the tumor? And am I going to have to expect to be seeing that? Or, well, no, it's not. The carotid's engulfed, but the basilar is not. The PCOMs are visible here, close to the capsule of the tumor. Knowing all that facilitates the dissection. You know what to expect. You've already explored the blind side of the tumor. Very useful. So, Greg, let's take a look. So, Greg Gates is a technologist who works with this company that we're working with, Surgical Theater. There are other companies doing some virtual reality work in healthcare, but I'm specifically talking about this unit because this is the only one that can do this kind of interaction. So we're going to use an Oculus headset. It actually has built-in earphones, so I can hear 3D sound, which is important in games and in other environments, not so important in the medical application. And for this, instead of using those hand controllers that I showed you that allow you to walk around, I'm going to use a gaming controller with multiple functions on it. And so here's that skull-base tumor we just took a look at. Okay, so now I'm seeing this. You should be able to see what I'm seeing on the screen here. So what I can do is change each individual element of the image to have it look different, and then I can maneuver and virtually see. So this is the kind of view we would get initially through the supraorbital craniotomy. This is the angle that we'll see that tumor from. Now, obviously, the brain as a digital object has been completely subtracted, so I can see the anatomy without the brain in the way. We can't insert the brain and see what it's going to look like there. But I can also fly right into this. So now I'm inside. I'm inside the cranium. If I look up, I see the roof of the skull. If I want to look at the backside of the tumor,
There's that basilar artery we just talked about. And if I look down, there's the foramen magnum and C1. They're the two vertebral arteries coming in. You can look at you can see the level of detail that's possible. There's the internal auditory canal. And the question is the basilar in contact with the tumor? Well, no. There's like a millimeter space right there. You can see that I'm not quite engulfed or touching the tumor. However, look at the carotid artery there at the clinoid. You can see it's surrounded by some tumor. So that's got to be taken into account during the operative procedure. But there's a foramen ovale and the foramen rotundum and the superior orbital fissure. The relationship of all these structures you can see through the partially transparent tumor where the carotid artery is, and I can come right up to it and really look at it in great detail here. And so you get a tremendous sense of what we're going to be seeing. The other interesting thing that we can do now, Greg, are you going to be able to trigger those? Let's look at the pre-op image. So what we can do is embed additional content into the 3D model here. So we've embedded the pre- and post-operative scans and some clips of the surgery. So there's the pre-operative MRI scan. I can see that scrolling through right here in front of me. And now let's go over to the surgical video there, Greg. So we've embedded some diagrams on how the case is going to be done, what the initial stage is going to look like, and here's the video from that particular case that I just showed you. Got a little bone on the orbital roof that's in the way. Here's the tumor under the frontal lobe. We have about a centimeter and a half of elevation of the frontal lobe. We're working on the tumor now, bit by bit. So that's all you see. That's how much of the tumor you see. You can see the optic nerve there, but I know where everything is because I've already flown around it and explored it in great detail. Okay, Greg, let's go to the post-op image. And so there we can trigger a view of the post-operative image right there. So let's go to the next case, the AVM case, if we could, Greg. Okay. So I hope you can see that on the screen here reasonably well. It's but I'll tell you, I am completely surrounded by the anatomy within the headset here. It's a very compelling experience, and Greg will be happy to allow you to come up and get a demo of this after. So with this controller, I can move up and down with one thumb control. I can zoom in and out with the other one. I can actually slice the image in a planar section. I can change the contrast of different elements with a control. So there's a lot of control that you've got with the hand controller. Now this is an AVM case that we did recently. And this AVM sits on the superior surface of the cerebellum. I decided to go in through a occipital interhemispheric approach and divide the tentorium. So we need to see exactly where that straight sinus is. There's a straight sinus because we're going to make an incision just below that in the tentorium and then find the AVM. Using MRA and MRV, we can segment out the veins in blue and the arteries in red, and we can even show the embolic material in the AVM after the embolization, if you want to add that, Greg. So there are the arteries alone with the embolic material. You can see this is a suboptimal embolization because it's largely in the feeding arteries,
and a lot of the AVM nidus remains unoccluded, but still helpful in controlling some of the inflow to the lesion. And so again, I can fly around from every possible perspective. I can make the skull transparent and see exactly, even from outside, look at it from every possible angle. See the feeding arteries in detail. Can you add add the draining veins, and you can take out the embolic material if you want. Yeah, and then trigger the one that says opening there. So this is another one with embedded video content from that particular case that allows us to see exactly what's going on. So this is the kind of multi-dimensional construction that we're putting together as teaching cases. So our archive now includes about 350, 400 cases. And the global archive is thousands of cases from around the country now. So we're going to be using those in that teaching environment to teach individuals on different techniques. And the residents are using this more and more for teaching. So Greg, thank you. So let's see if we can let's see, we have to switch back to the projector here. We have to probably do a reconnect. So we're using this now for vascular malformations, cavernous angiomas, skull-based tumors, gliomas as well. And with every case, just like in the early days of image guidance, we're learning more and more how to use it to advantage. We can segment out individual structures. So here's skull, arteries, and tumor. We can add the ventricular system and CSF. And so each individual layer can be manipulated, made opaque or transparent or subtracted completely. And then you saw the embedded video content. We can put labels in the images so that when you fly in, they're triggered. So historically, we've learned from surgical atlases with medical illustration in them and text. Now, we're using real cases with the real video from the cases and the text embedded in the three-dimensional image. It's a new way of presenting surgical teaching. Embedded video like this. People have done some scientific studies and measurements of the impact of virtual reality, and in laparoscopic abdominal surgery, it's become more and more important. It has been stated to improve operative performance and shorten OR time, and does accelerate the acquisition of a certain degree of proficiency. And even meta-analyses, VR versus these physical box trainers for endoscopic training has been compared, shows an advantage for the VR versus video trainers, the same thing. So we're beginning to see some evidence accumulate that it's really useful. The next iteration really is going to be, obviously you can't operate wearing an Oculus headset because all you see is the virtual anatomy. You can't see anything in the room. You can't see the scrub nurse. Ideally, what you would like to see is virtual objects superimposed on the real environment, and that's what's beginning to become available. Now, this is a demonstration of what things look like with a Microsoft HoloLens head unit. It allows you to see the environment with this headset, but it superimposes virtual elements like that. And there are some YouTube videos you can see online that show you what that looks like. It is, it's coming along pretty well. They're beginning to explore the uses of it for medical education. But this is really what you want. You want to be looking at the patient's head and see the brain and the blood vessels and the functional areas and the DTI superimposed and perfectly registered anatomically. You want 3D X-ray vision in the operating room, and this technology is going to get you very, very close to it in the future.
So these are the sorts of things that are actually available today with commercial products, and you can and begin to use them. I think we're going to see ever-expanding applications of this kind of advanced visualization in the medical field, and particularly in surgical training, in surgical planning, and even intraoperative image guidance of a new sort. But this headset, take a close look at this. In the future, it's going to be a pair of wraparound sunglasses, and the computer is going to be the phone in your pocket. And some people are saying all computing is going to be done in that modality. You're going to be picking things out of the virtual air. You're going to be using hand gestures, even gaze-related, using gaze as your cursor is the way the future is going to be. So what I just showed you, that Oculus headset, is the equivalent of that. So you remember the movie Wall Street? Everybody was amazed because Michael Douglas was sitting at his beach house talking on his cell phone. Well, this is where things started. But now, you know, technology is moving so fast that in 3 to 5 years, we're going to move from something the equivalent of that to something the equivalent of an iPhone. And we're going to see tremendous changes in the way we do everything in medicine. The applications of things like virtual reality, artificial intelligence, machine vision, big data, cloud-based services so you can have access to any information anywhere is really going to change things dramatically. You know, in today's world, here's one little indication of how things have changed in our lifetime. When you wake up in the morning, what do you do in the first 10, 15 minutes that you didn't do 20 years ago? You check your cell phone. And the way we do surgery is going to change in the same kind of dramatic way. So you know, it's going to be a fascinating time to see what develops over the next several years. And from my perspective, I'm viewing this early prototype, it's now commercially available, this early prototype as our portal into the future. And it's going to be a conduit for big data analytics and machine vision and cloud services and other advanced types of software. So I see this as a big step in our migration to a whole new generation of surgical services. So I wanted to share my experience with you and my excitement about where we're going to be going, and I'd be happy to take any questions. Thank you.